that what we talk about today is going to have relevance for all of the contexts in which you work. So I personally am a clinical psychologist by training, and my background is in trauma and grief and loss and meaning making. And so most of my work intersects with at least one of those topics, if not multiple of those topics. And in my job with integrative mental health, as Tim mentioned, I focus a lot on working with teams of mental health providers and chaplains who are engaged in collaborative care, largely around moral injury, also suicide prevention, and some other areas. So that's sort of what I'm coming to you with today. And let me see if I can successfully share my screen. Let's see.
There it is.
And excellent. Let's see what happens if I put it in presenter view. Do you see a full slide or my note slide?
It's a whole screen, yeah.
Excellent. Okay, very good. Okay. That does mean, unfortunately, that I cannot see you guys. So please do speak up and interrupt me. Feel free to do that. I'm very comfortable with that. I'm comfortable doing this conversationally. So if you have a question or anything that I can answer, or that you just a comment you want to make or a point you want to raise, please do so. But yes, I will need to hear you. I won't be able to see you if you want to interject with something like that. I do want to acknowledge that the views presented today are my own and do not represent the views of the Department of Veterans Affairs or the United States government. So in our time together today, I really want to focus on three main questions, and those are: why collaborate in the first place in providing care to patients? Why mental health and chaplaincy in particular? And what might or what could collaboration look like? And so this third question will get the majority of our time today, exploring different ways to think about and approach collaboration. And I understand that you do come from a diverse array of care contexts. Some of what I say may apply, other things may not. And so I ask you to simply bring an openness to ideas that might serve you, and feel free to leave the rest. Lastly, we do have a kind of a bonus topic for today, which was requested by someone who completed the survey, perhaps one of you, perhaps someone who's not here. And many thanks again to Tim for sending that out. We actually ended up, Tim and I, in discussion, shifting the direction we would go today based on that feedback. So again, I hope that those of you who are here today see some of your questions and ideas reflected in what we talk about. So one of you asked us to talk about unrecognized or unresolved trauma that chaplains may experience as a result of caring for patients who've experienced trauma. And so to close us out today, I do want to spend a little bit of time focusing on those topics. All right. Okay, so without further ado, let's start with the question of why. Why collaborate in the first place? Now, the literature, the research literature on this question suggests reasons, which you can see on the Post-it notes here, that I think are fairly common sense. Interdisciplinary collaboration can help us solve real-world complex problems. Why? Well, because different disciplines bring different perspectives, and two heads are generally better than one, right? And that's not two of the same head, that's two different heads with two different perspectives. So it just makes sense that bringing that together would be helpful as our problems become increasingly complex and difficult to solve. There are other reasons that are cited in the literature that have to do with things like generating hypotheses for research, defining clinical syndromes or problems, like coming up with what those definitions are, thinking through clinical care guidelines, as well as providing comprehensive clinical services. And I just want to illustrate this. We probably all understand what I mean, but let's think about, for example, how we would care for someone who's been in a car accident, right? So there's the emergency responders who are on the scene. They focus on survival and stabilization. And then there's the surgeon who tries to fix whatever's been broken. There are the physical therapists who help the individual recover their mobility across time. And ideally, there are mental health providers and chaplains who help the individual deal with the emotional and spiritual effects of the accident. So if any one of those disciplines was singularly responsible for defining the problem in terms of what needs to happen when someone's been in a car accident or what that care should look like, that patient would be woefully underserved, right? Working together is essential if we want to holistically understand and assess and care for people. And sometimes working together in this way is built into our systems, which is great, but other times it's not. So you might work in a context where disciplines are siloed, where you're essentially cut off from understanding and appreciating what other professionals do and how each of you can contribute to the greater whole of caring for patients. And so what is the risk involved if we settle for these, specialty silos and don't pursue collaboration? To illustrate this, I want to read you a short story that's an old tale from India, and I came across it in this book. I'm not sure if you can see that, The Wounded Healer by Henry Nouwen. Some of you, maybe all of you, are familiar with that. And if you have read this book, you know that Nouwen approaches it from a slightly different perspective than the one I want us to use today, which is to focus on collaboration. So as I read this story, just listen to it with a collaboration lens in mind. So the story goes like this. 4 royal sons were questioning what specialty they should master. They said to one another, "Let us search the earth and learn a special science." So they decided, and after they had agreed on a place where they would meet again, the 4 brothers started off, each in a different direction. Time went by, and the brothers met again at the appointed meeting place, and they asked one another what they had learned. "I have mastered a science," said the first, "which makes it possible for me, if I have nothing but a piece of bone of some creature, to create straight away the flesh that goes with it." "I," said the second, "know how to grow that creature's skin and hair if there is flesh on its bones." The third said, "I am able to create its limbs if I have the flesh, the skin, and the hair." "And I," concluded the fourth, "know how to give life to that creature if its form is complete with limbs." Right? So the collaboration here is obvious, right? They're really working together for something important. Thereupon, the 4 brothers went into the jungle to find a piece of bone so that they could demonstrate their specialties. As fate would have it, the bone they found was a lion's, but they didn't know that, and they picked up the bone. One added flesh to the bone. The second grew hide and hair. The third completed it with matching limbs, and the fourth gave the lion life. Shaking its heavy mane, the ferocious beast arose with its menacing mouth, sharp teeth, and merciless claws, and jumped on his creators. He killed them all and vanished contentedly into the jungle. So now you know why there's a lion on the slide. And I'm sharing this story because I think it illustrates that, when, yes, these specialists all brought this unique perspective, this special skill, but they didn't take the time to really think through the implications of how bringing those things together could manifest, right? In this case, in something that actually killed them. I don't think that we're so much at risk for that. But I do want to argue that when we're doing something as complex as caring for the hearts, the minds, and souls of people, it's really essential that we understand and appreciate what every other person is bringing to that equation, so that we can be aware of the potential consequences of the work that we're doing and not be pretending that we're the only one who has an impact on this individual.
Hey, Melissa.
Yeah.
So let me add so I was a pastor for a while and just went this last week to Billings to go to my endorsers conference, or basically our annual denominational conference. And one of the guys who was he was a former superintendent of our district conference. We were having dinner together, and he was asking about, he said, "Hey, you're kind of in the mental health field now." And I think that's an interesting comment by itself. But he said, "I'm just kind of curious." He's like, in my world, if somebody comes in and talks to me about some kind of a counseling type of an issue, I think every problem has at its core a spiritual base. Like everything is discipleship. And so I said, okay, so why are we making that distinction? Do we think God is into the spiritual side, but had nothing to do with the mind and the body? Like, from my theology, didn't God create all of that? And so the question, even in the church, from a church perspective, and this is the tradition I came out of for sure, is that, well, at its core, if we have the spiritual side taken care of, the other pieces will kind of fall into place. So it's kind of illustrate your point from my tradition before chaplaincy. That's a pretty common view. I would guess it's probably common with mental health folks thinking that the problems are grounded in mental health, and doctors thinking, well, let's get a healthy body and the others will fall into place.
Yeah. I mean, I think we probably all can agree like that totally happens, right? And we're probably all guilty of it. When we see a person who's suffering, we naturally see it through the lens of what we have to offer, right? Which in some ways is great because we're looking for how we can have an impact. But I think in the context where you all work and where I work, we have patients showing up with incredibly complex needs that have complex etiologies, complex, sources from which they come. Actually, this is a nice segue to the question of, okay, yeah, so if collaboration is important generally, why is it especially important for mental health and chaplaincy or spiritual care providers? And so I want to use these bubbles as a metaphor for this. So let's say this bubble on the left is y'all, that's the chaplains. And then the bubble on the right is me, that's mental health. Okay. And so we're both just floating along, doing our thing, providing our care. And then at some point, there's a person in distress. Let's see, there's my person. Okay. So this person is looking for help. Okay. And so from our system's perspective, they've got two options. They can go to the chaplain or they can go to the mental health professional. So who should help them? Right. That's an important question. Who's most equipped to help them? Well, as Tim was alluding to, it kind of depends on the nature of their stress. So what's going on with them? Are they feeling stuck? Are they feeling depressed, lonely, anxious? Are they struggling? Are they lost? Are they sick? Are they sad? Are they frustrated? Right? Who should they see based on what's going on with them? Now, you're probably thinking that it depends. And I would say you're right if that's what you're thinking. So, if someone says, oh, I'm depressed or anxious, that might sound like the purview of mental health. But what if the source of those feelings is intimately connected to something about their faith? Similarly, words like stuck or lost might conjure up more spiritual or existential kinds of associations. And so we might think that, oh, well, if someone is, feeling lost, that's more the chaplain's domain. But what if the source of those feelings, that struggle, that sense of lostness, is actually the result of having experienced a traumatic event that the person can't even bear to think about, let alone make meaning of? Maybe they need some help in a mental health kind of way to be able to access those memories and be okay. So the reality is that our disciplinary bubbles, chaplaincy and mental health, are not siloed. We float along very near each other, sometimes touching, connecting, even combining. Imagine, when you blow bubbles with a kid and they start out as separate bubbles. And sometimes if you watch, you'll have two that come right up next to each other and actually combine. Right. And I think that that's what our emotional, social, and spiritual lives and needs are like. They're often interconnected, like this mess of bubbles. And so it's difficult, if not impossible, to tell exactly where the boundaries are. And so it would be great if I could stand here today and tell you all, here's where the boundaries are. If it's this thing, it's your job. If it's this thing, it's mental health's job. But unfortunately, or perhaps fortunately, that's just not the way we're built. And so what do we do with that? That could be a huge liability when it comes to care, where we're either feeling responsible for stuff that's really not our wheelhouse, or we're blaming somebody else. But I actually think that it's really an opportunity for collaboration. And so that's what I want to talk to you about in more detail today. And I do some research, so that's part of my identity. And so I want to hit you with some data real quick so that you know, hey, this isn't just Melissa's idea. There's actually some research that backs this up. So this slide is from a survey that we conducted about 10 years ago with a bunch of VA and military chaplains. And when I say a bunch, I mean, we had some high response rates to the survey. It was like 75% of VA chaplains and about 60% of DoD chaplains responded. And so that gives us some confidence that these responses are in fact fairly representative of the attitudes and beliefs of these VA and military chaplains. So what this slide shows is chaplains' level of agreement with certain statements from that survey. So as you can see from the first statement, a majority of chaplains in VA and then especially DoD view themselves as being on the front lines of care for veterans and service members with mental health problems, right? So these chaplains are perceiving that they are commonly turned to, at least initially, instead of mental health professionals by people who have mental health problems, okay? So there are surely many reasons for this, but one of them that we know is stigma. And you can see in the next two statements that chaplains acknowledge the potentially stigmatizing effect of seeing a mental health provider versus seeing a chaplain. And this can be especially true in the military context. Encouragingly, though, there was nearly universal agreement among chaplains that collaboration with mental health is indeed possible, and that the role of mental health professionals is highly valued. We actually did some site visits as part of this project, and many of the chaplains that we talked to on those visits talked about viewing themselves as important liaisons who can help destigmatize entry into mental health care services for those who need it. Okay, so to just summarize again what's here, veterans and service members with mental health problems turn to chaplains, perhaps because of stigma, probably other things too. And chaplains are willing to collaborate with mental health when that happens. So this bodes really well for what we're trying to do. But what do we do with the murkiness surrounding psychological problems, spiritual problems, right? Like it's a messy, messy world in there. So what do we do about that? Who should do what? So another part of the survey that we did with these chaplains was to ask them about different job activities and to ask them whether those activities were more the chaplain's scope of practice or the mental health professional's scope of practice. So we gave them a list and we basically said, to what extent do you view blank as a job component for chaplains and a job component for mental health? And so they could categorize it as not a component or a minor component, a moderate component, or a major component. And they did that for both mental health and chaplaincy for each job item. And so then we were able to plot those responses on this graph, which is what you're seeing here. So I want to orient you to why things are the way why things are where they are in this graph. So the closer something is, and I hope it's big enough that you can read those little words, the closer something is to the top of the graph, the more chaplains said it was a major component of the chaplain's job. So as you can see, if you look at the bottom, providing psychotherapy and diagnosing mental health problems are not considered the purview of chaplains by chaplains. While by contrast, spiritual assessments and attending to spirituality are closest to the top. So those are the things that were most highly associated with the role of the chaplain. Okay, so it makes sense, top and bottom. Similarly, the farther something is to the right side of the graph, the more chaplains said it was a major component of the mental health provider's job. So you can see that the items that are farthest to the left are things like praying with patients and engaging in religious activities with them, right? Those things are not the purview of mental health. While looking at the right side, attending to mental health and diagnosing mental health problems are the purview of mental health. Okay, nothing I've said so far is rocket science. What's interesting about this graph is all the stuff in the upper right quadrant. Things like addressing guilt and forgiveness, inviting veterans to tell their story, veterans, patients, you can fill it in, providing counseling, enhancing resiliency, Okay, these types of things were identified by chaplains as being major components of both the chaplain's job and the mental health provider's job. In other words, we do really similar work a lot of the time, but we still come at it from different perspectives. Tim mentioned earlier, in this moral injury realm, we deal a lot with guilt and forgiveness, and it is incredibly fascinating and incredibly valuable to have diverse perspectives on those topics, because every person who comes to our group has their own pretty deeply entrenched ideas about those topics. And it serves us to have at least two different perspectives from the facilitators of the group, because it gives more opportunity for the individual veteran or patient to feel like someone understands where they're coming from with their own perspective. Any questions about what's on this slide? I know it's a busy one. Okay, so if our worlds overlap considerably, as we know they do, and if collaboration is desirable and something that people are willing to do, how do we do it? What does it look like?
Hey, Melissa, I'm sorry to be a late questioner, but on that chart, that was based on questions to chaplains about their perception of the role of chaplain versus mental health.
Correct.
Okay, so they're seeing, if I'm getting this right, they're seeing their primary on the top left.
Anything toward the top is major for chaplains. So
Okay.
We've got bottom to top, left to right, and then it converges in the top right.
Okay.
That makes sense? Yep.
Yeah. Okay.
Great
I would
question.
be curious on the therapist perspective on this too, but
I know. And I
another
wish,
topic for another time. Yeah.
I wish we had that data. We did this survey with chaplains and we don't have it, but we should.
Yeah.
Yep.
Okay. Thank you.
Absolutely. Any other questions? Okay. So I want to give you a framework for how you could think about collaboration across three levels: awareness, intentional engagement, and co-facilitation. As collaboration progresses through these levels, collaboration becomes increasingly nuanced and complex. So co-facilitation is a form of sort of advanced collaboration that wouldn't be possible without the foundational experience with creating awareness and fostering intentional engagement. So I want to go just a little bit more in depth on each of these levels. The first one, I love using pictures of animals in presentations that I do, so this is why you're seeing a polar bear. So awareness is a necessary but not sufficient condition for collaboration. When it comes to collaboration in healthcare systems, awareness involves, I'm speaking to you as chaplains now, knowing who your mental health colleagues are and having some idea of how they function. So for example, in the VA, we have some social workers who are not involved in clinical care and others who are. So that would be an important thing to know. Like, any given social worker may or may not actually do clinical work. Similarly, we have psychologists and social workers who work in specialty mental health clinics, like for PTSD, and then others who work closely with primary care or other types of medical providers. Now, you don't have to be an expert in all of these areas, but it does help if you know some of the basics at your facility in terms of how mental health is situated and how it functions. So for example, if you approached a social worker who doesn't do clinical work, wanting to ask them to co-facilitate a group with you, you probably wouldn't get very far. And hopefully that social worker would help point you in the right direction. But I'm sure you've all had an experience, or at least I have, where colleagues in the system are not always as helpful as they could be in helping to provide some of that education. So doing what you can to understand how mental health providers function in your system can be an important foundational step to being able to engage with them. Now, the reverse is also true. Mental health needs to know a thing or two about chaplaincy. And I wish I could say that our disciplines are approaching each other on a level playing field, but in my experience, that's often not the case. simply because mental health is typically a much larger department than chaplaincy, which can mean that it's more well-known or more integrated into more places. And so it can be just sort of assumed more easily. Whereas people don't always have the same level of understanding of chaplains and of chaplaincy and of what you all offer and do. And so that does unfortunately mean that sometimes chaplains have to do the extra work to get mental health providers' attention to be able to do this kind of collaboration. And I say that very humbly because if it weren't for the chaplains who took the time to educate me about what they do and the possibilities for collaboration, I wouldn't be doing anything that I'm doing today in my job. So I recognize that it's not necessarily fair that the onus is often on chaplains to do some of that preliminary bridge building work. And at the same time, you as chaplains are typically in a unique position within your systems where you serve both patients and staff. And so I think you may be in a unique position to leverage that position to build relationships with other staff in a way that mental health providers perhaps don't have as much latitude to do. I do want to share one comment that was submitted with the survey that we sent out. One chaplain said that there's a need for chaplains to offer additional education on our role. This person said that too many times there's a thought that social workers can fill our role. We complement one another, but I cannot or would not want to fill their role. And I just wanted to highlight that, and I appreciate that comment and frankly agree with it wholeheartedly. It could be the case that chaplaincy is less well known or understood compared to other disciplines. And so I want you to see that as an invitation to take a seat at the table and let the rest of us know who you are and why you're there and what you can offer. And I can almost guarantee that in our current environment where nearly everyone feels overextended and pressured, learning about another competent, caring professional who can help shoulder the load of caring for patients, I can almost guarantee that that would be a welcome notion. Okay, so if you find yourself not wanting to speak up and assert what you do have to offer, I would challenge you to challenge yourself to do that, because the rest of us, yeah, we can be ignorant sometimes, and we need you to help us understand. All of that being said, this awareness is just the first step, and actually working together is more the stuff of level 2, which I'm going to talk about in just a minute. But before I do, you're going to get a copy of these slides, and this slide is an exercise that you could potentially spend a few minutes on after our time together today if you want to. And the goal of it is just to help you identify and understand where you are now in your local care context in terms of collaboration. And in so doing, to clarify where you might like to go or where you'd like to be. So you may be familiar with this kind of activity. It's referred to as a gap analysis or a current future state exercise. And so the questions that I would encourage you to think about are listed here on this slide. Again, I invite you to come back to this later if you really want to assess your current state when it comes to collaboration. And my advice to you on this, if you choose to do it, is to write it down. Write down your answers. There's something really powerful about getting things out of our heads and onto paper that can help us really realize what's going on in our context. So just an invitation if that would be useful to you. Okay, so let's get back to our levels. So building on awareness, intentional engagement is the next step. And so this is a model that we've used in our work in the VA and DoD contexts. And again, it may not all be relevant to you, so just pick and choose what you feel like you can apply where you are. So we've got 3 points on this triangle, and each one has 2 components. The first point is patient flow. And so 2 areas for intentional engagement that stem from patient flow have to do with screening and referrals. So screening could focus on evaluating what are the current practices in your facility for identifying patients with spiritual issues and or with mental health issues. It could be that there's already a robust intake process for mental health that could be supplemented with just a couple of questions to identify potential spiritual issues that could trigger a referral to chaplaincy. And that referral part is kind of the second part of the equation. So what are the current referral processes? Tim and I were both encouraged by the survey results to see that a lot of you seem to have the ability to refer back and forth between mental health and chaplaincy, which is fantastic. That's not always the case. So you can look at what are those processes, if they exist, how well are they working, how well are they understood, how closely are they followed, is there anything that can be done to enhance that? You could even think through, how well in your referral processes is the core issue communicated, right? It's not just about who the patient is, but what's the issue that they need? What might a basic care plan look like? Those sorts of things can all be part of thinking about our screening and referral processes. Professional practices kind of builds on that by looking at our assessment practices and communication and documentation. So kind of like the screening and referral, the assessment process could entail developing if nothing exists, improving if something does exist, or ensuring the use of multidimensional assessments for spiritual and mental health issues. And that can really facilitate those referrals if we're having something systematically administered to patients. When we are striving to provide relevant information to others, we do that through communication and through documentation. And this is a place where we can experience tremendous breakdowns, but also can see pretty rapid improvements if we make some tweaks in this area. So some questions to ask yourself would be, do you currently have regular communication practices with mental health, perhaps as part of regular team meetings or something like that? And if not, what might it take to institute something regular and consistent that both professions can rely on? Another question would be, do you consistently document care and consults in a manner that's useful to other disciplines? Now, I don't know what the documentation requirements are in the different contexts where you work, but for those of you who are accustomed to a lot of documentation, you've probably encountered some notes in the medical record that tell you basically nothing, and they're very unhelpful. And you've probably encountered some that are super helpful because the information that some other provider has managed to convey is stuff that you can use, that can save you time in the care that you're providing and kind of give you a leg up when you're meeting with that patient. So I would encourage you to evaluate your own documentation practices and ask yourself, are you communicating useful information in a clear and concise way? If you do that self-assessment and determine that you're not, again, I think this is a place where you can really quickly see relational traction built, because if you focus on providing clear, concise, useful information, other providers will notice. They may or may not come back around and thank you for it, but they will notice, and that will create some good juju for building relationships on. All right, and the third point in the triangle is focused on interdisciplinary relationships. And here we focus on role clarification, which we've kind of been talking about this whole time, as well as cross-disciplinary training. So role clarification between mental health and chaplaincy, as I said at the top, I can't give you the list of everything on this side is chaplaincy, everything on this side is mental health, because there is so much overlap. But role clarification can be very helpful when we're able to talk directly with the providers from the other discipline that we work with to identify together, okay, how are we going to handle these sorts of things? If somebody shows up in my office and they're, what is the point at which I'm going to make that referral to you, chaplain, and vice versa to you, mental health provider? And working together to establish what each person's role is going to be can really make things more efficient, so that you're not constantly having to go through a decision-making process, but you've actually got something that you've agreed on and ideally written down and made it something formal that you can rely on. Cross-disciplinary training is, I think, another opportunity to I know this is a triangle, but if you think of it as like a circle or a wheel, this is a way to keep the process moving. I don't know if any of you are involved in training residents or interns or whatever they may be called at your facility, but when we can pursue interdisciplinary, cross-disciplinary training, when we can get people from different disciplines trained together at the same time, it can reinforce the idea that, hey, we have a lot in common. Hey, we should be working together. Instead of saying it's a good idea for us to collaborate with each other, let's actually get our trainees together in a room. Let's get our staff together in a room and learn together simultaneously. And we are then just sort of putting that in the water of this is how we want to approach collaborative care at our facility. I know that was a lot of words. Anything I can clarify or any questions about any of that? Well, if you are intrigued by any of that, we've got actually a number of videos that we've put together that talk about these things in more depth from the project that we did within integrative mental health. And so this website, you can visit that. That'll be on the slide, and you're welcome to dive deeper with those videos. Okay, so I mentioned before, co-facilitation is sort of an advanced level of collaboration that can be made possible when we've got the kind of strong foundation we've been talking about. The photo on this slide shows a group of chaplain mental health teams who participated in a project with us in 2019-2020. And they were involved in some pretty high level co-facilitation and collaboration. I'm going to give you two examples from a moral injury group of what is possible at this level. So in both examples, it's a chaplain and a mental health provider who are co-facilitating a moral injury group. And both the chaplain and the mental health provider were involved in recruiting patients to take part in that group. And they both encountered resistance to the other discipline. So one veteran that the chaplain recruited was not interested in working with mental health because of the issue of stigma that we noted earlier that was kind of hanging on from their days in the service. But this veteran was willing to be in a group with the chaplain who he trusted. But once he got going in the group and was encountering this mental health professional, he was a little surprised to realize how much this person seemed to understand about his struggles. And through that provider's gentle questions over time, he came to realize that he was in fact suffering from PTSD, and he agreed to pursue treatment for that decades after his war experiences, all thanks to the chaplain advocating for him to participate in this group that was co-facilitated with mental health. Now, the opposite is also true. So we had another veteran who was pretty much in the opposite boat. He had been working with mental health for years and had successfully reduced PTSD symptoms, but was still struggling with meaning, finding meaning and purpose in his life. He didn't know why he was here and what his life was for. However, he had no interest whatsoever in talking to a chaplain and was even hostile to the idea of it because he had experienced rejection from his church family after returning from service in Vietnam. And so he had just sort of turned his back on the whole thing for decades.
Melissa?
Yeah.
Just wanted to insert, there's a question in the chat kind of connected
thank
to
you.
this. Do you have any ideas how to approach our mental health workers when they are resistant to collaborate?
Boy, that's a good question. So my honest answer is see if you can find somebody else, because your time is precious, your energy is precious. And if you can devote it to someone who seems receptive, it might be worth spending your effort finding that person rather than trying to just, continually going to head with someone who doesn't seem like they want to partner together. And hopefully with it being a numbers game and having more mental health providers, hopefully if you just keep looking, you'll find someone who has some interest. I'll keep going for now just because of time, but if there's feedback on that or further questions, please do put them in the chat. So long story short, with this other veteran, he was on board with mental health and through this collaborative group was exposed to a chaplain who gave him a different experience than what he had had from that church leader who had rejected him all those years ago. And he came to be able to explore his own spirituality in a way that, again, he'd been just completely shut off from for years and years and years, thanks to the chaplain in that group. So I think these examples just illustrate that co-facilitation can really open doors beyond what any of us can do on our own. For the sake of time, I want to ask you all the vicarious trauma question. Do you want me to make sure I get to that, or do you want me to spend a little more time on these collaboration themes?
I vote for vicarious trauma.
Okay, so you can read these slides on your own. Thank you for voting. So yeah, you can read all of those on your own. Okay. So I want to acknowledge that I am not an expert in burnout, vicarious trauma, compassion fatigue, but I did want to put all three of those terms up here in case any of them are new to you, because I think all of these, in addition to moral injury, represent professional risks that we face as the kind of care providers that we are. So chances are many of you have heard of burnout, and there are lots of definitions. If you Google any of these terms, you're going to see a lot of different things. I tried to pull out what I think are some of the distinguishing characteristics. So with burnout, it's feelings of just being depleted, being exhausted, and that goes along with a general negativity, often cynicism about one's work. Okay, so it's focused on the job itself, and can, yeah, that's kind of where the focus is. And someone who's experiencing burnout may be able to then go and engage in a beautiful way with their family, with their, social groups, whatever. But when it comes to work, that's where that like negativity and cynicism kind of is focused. That's different than vicarious trauma, sometimes called secondary traumatization. And this is when exposure to, it results from exposure to trauma that's experienced by the patients that we care for. And this can lead to a range of psychosocial symptoms. So vicarious trauma can actually look like mental health problems in oneself. It can look like depression. It can look like anxiety. It can look like avoidance. If someone is not wanting to come to work because they know that when they go, they're going to have to hear these horrific stories from people that they don't feel like they have the bandwidth to hear or the compassion to care for, we'll get to that in a second, that could be a sign that a person is experiencing vicarious trauma, which is different than burnout. Because if a person is just like, I'm just sick of the grind, I don't feel like my work makes a difference, that's different than when I go to work, I feel like I can't handle what's being asked of me because of the traumatic nature of it. Okay, so that's a little kind of how that vicarious trauma fits. That's distinct from a third thing called compassion fatigue. And this is when a person has just been hit with so much need, and it results in a diminished capacity of that person to care for the needs that are presented to them. And this can be a consequence of just repeated exposure to patient suffering, which is our jobs in a nutshell, right? So compassion fatigue, as distinguished from these other ones, can look like apathy. It's not necessarily burnout in the sense of like, it's not that I don't think that my work makes any difference, but I just can't do it. And it's not that I can't do it because it's, giving me nightmares at night. That might be more of a vicarious trauma kind of indicator, but I've lost my will to care, might kind of be what that sounds like. All three of these things have been around a little bit longer. Moral injury is a little bit more new. I'm going to mention it. You can definitely talk to Tim if you want to hear more about it. Moral injury can result when there's been a betrayal of what's right by something that a person has done or something that's been done to them. And moral injury results in characterological change. So it's not just, I'm experiencing some mental health symptoms as a result of the difficult thing that I went to. I actually see myself and other people and the world fundamentally differently. So moral injury is, I would say, the most extreme of the things that are on this slide here. Hopefully that's enough of a little bit of distinction among them that you could follow up with, again, Googling any individual one of them to learn a little bit more. But I wanted to give you just a couple of questions to do a bit of a self-assessment. How am I feeling about my job these days? How am I feeling toward my patients? How am I feeling about the work that I'm asked to do? Have I done or experienced something that went against deeply held moral beliefs and values? So each of those questions kind of coincides with one of, in order, the things on the previous slide. And just let that be a jumping off point, perhaps for some self-reflection. And I want to leave you with the thought on self-care. I think self-care can be trivialized really easily, especially with everything we've all been going through lately. And I hope it doesn't feel trivial for me to quote Mr. Rogers in this moment, but I think this quote, he says, "Some days doing the best we can may still fall short of what we would like to be able to do, but life isn't perfect on any front, and doing what we can with what we have is the most we should expect of ourselves or anyone else." And I think this is a form of self-care, or that's really rooted in self-compassion. So if you do find yourself struggling in any of the ways identified on the previous slide, I think self-compassion can be an important step in moving forward, whatever the kind of specific struggle may be. So yeah, I know we're at the top of the hour, so I'm going to leave you with that thought and turn it back over to Tim.
Melissa, let me just ask, one thing came up in chat: would moral injury include things failed to be done or an inability to intervene?
Yes, absolutely.
Yeah, so in the way that connects is like, this is something I have a belief system or conviction about something. I witnessed that being violated, but I couldn't or didn't do anything to intervene. And so I feel somewhat responsible. What if, right? Something like that.
Yep, nailed it. Yep. And that can be really common in healthcare settings where we want to do things that we're not able to do for one reason or another.
Yeah, basically, yeah. And that could be even like in our role as chaplains, where we would like to be able to help or be a part or integrate into the care, but aren't allowed to, or it gets away from us, or don't have time to.
Yep.
And so something happens and we're left sweeping it up, maybe with staff care, but weren't able to be involved with the patient or family.
Yeah.
A lot of this, as you were talking about this, Melissa, and thanks for the time putting that together. That's really appreciate that. This can also, there are a couple of things. One is, how many of our hospitals, and I think Karen and I were talking about this yesterday, have some kind of mental health as part of the care system. Karen, you were talking about the acute unit down the road, just lost how many providers?
Most. I think they're down to like one or two.
Yeah, and this is Billings.
Yeah.
So, yeah, so if somebody comes in for suicide, I think it was Gary who was saying somebody was taken in for suicide and were sent home, basically, you're fine. But really is that we don't have capacity to take care of it. Turned out poorly. So yeah, this can happen with, if we have capacity to refer to mental health, or if mental health has capacity. What I've even learned around here is, as I get involved in caring for some of the needs of the provider, they experience what that does, and then they're more likely to refer or do a consult. But as Tricia mentioned, that is not an easy thing to build and to build up trust for. But
well, let me maybe, because I'm wondering if the question about how do we approach mental health when they're resistant, and I said find somebody else, and if mental health is leaving in droves and that's not an option, I do think if you have the capacity, and only if, finding some way to be useful to that person that you want to collaborate with. It could be in a very small way. It could be professionally. It could be, personally. If there's some way to show them that you care, that you're there, even that could be met with resistance, frankly, because we're not very good at accepting care from others. But I think you're playing a long game with this, and collaboration is not born overnight. And if you have a chance to look back at the slides that I went over, skipped over really, one of the things we talk about is that collaboration doesn't work if you just put any two people together. There needs to be some sort of foundation of, it's great if a mental health provider has some kind of personal spirituality and faith that they practice, because that means that they might have some regard for the value of that in the lives of others. Similarly, we've got a lot of chaplains who have mental health training of different kinds, or they've had a family member or personal experience with mental health issues, et cetera. And we can use those experiences to help build a foundation. But what happens with good collaboration is that it becomes a friendship. And so if you start in a place of just seeking to befriend another care provider, it may be a while before it manifests in professional collaboration, but that can sometimes be the place to start. I hope that helps a little more.
Yeah. Nate and I were just in a group yesterday where we were talking about doing postvention for suicide for families and for staff. It came about by a psychologist over in the outpatient providers who just went to a seminar, and they were presented with this postvention plan, a team that actually does this. And so she came back and she teams me, and she said, do we have any plan for postvention for suicide? Any way that we provide for that? And we had just had something in our Missoula clinic where we had a guy who called into the helpline, said that he was going to kill himself and take some other veterans with him. And somehow they were in this discussion, and the person in the, I guess an MSA or something, in the waiting area of the clinic there spotted the guy. And so they went on lockdown, and they went to a shelter in place, and then they got him transferred over to the mental health waiting room, which that's interesting by itself. And then they had an abandon the building kind of thing. But the question was, so what are you doing for that staff after that, for it's like a critical incident debrief? And that all kind of came together to a, hey, no, we should put something together. And there's another VA that actually is doing that. And so we collaborated with them. It's just that process of, hey, an incident happened. A provider is concerned of how we're taking care of our people. That will translate, like Melissa was saying, into an opportunity when something else comes up. Hey, let's get the chaplain in on this because they've proved helpful before, or concerned anyway. And so it's just time being there, I think, to some extent, and then the experience of something like that happening. However, that's the easy answer. The actually feet on the ground, having that happen is, everybody has a different situation.
Yeah.
Well, Melissa, thank you so much for taking the time. And I think even those questions would be some great things for us to discuss as teams with our staff, or, collaborate with each other. I will, can you send me that PowerPoint?
I will. Yeah.
And then we'll put that with the recording on our site, so you can have the discussion questions on there, download that. And what we've decided to do on this is to, like the month of a presentation, we put that on the homepage site, so it's available to anybody. And then after the next presentation, we switch that over to the membership site, and each month it's available for everybody, and then it goes onto the membership site after that.
Neat. Cool.
So we are working on topics for next year. And if you have some, Karen and I were talking about proficiencies for chaplaincy that we'd like to address, and we got a whole list of things. You got that? That we want to go to people who have specialties in that from among our group and maybe nationally as well. So we're starting to put that together. Any help or ideas that you have, or an article that Sunita just read lately that might be helpful for us in our next idea. That's context from a discussion we had at the beginning. But thanks, you guys. We'll send you back to your day. But we will see you guys next month, and Jenny and Treja on Monday. We'll see you. All right.
Thank you.
Thank you, Melissa.
Thanks,
That was
Melissa.
wonderful. Sure
Thanks
appreciate
for having me.
Yes, it was. Thank you. Thanks, Tim.
All right. See you all.